Hey folks, Aaron Robinson and Brian Driver here. Today we're going to be talking about supraglottic airways, also known as extraglottic airways. We're going to cover two main classes of them, the laryngeal mask airway class and then the laryngeal tube airway class. In the laryngeal tube class, we've got the King LTSD, which is a popular airway that has two cuffs on it. We'll talk about that. We've got the iGel, which is a really popular laryngeal mask airway in the pre-hospital setting. We've also got the AirQ3G, which is another popular airway used both in the emergency department and pre-hospital setting. And then the Teleflex ILMA, which is a intubating laryngeal mask airway that's used primarily in the emergency department setting.
Okay, so there's a few differences between the King laryngeal tube and the LMA style in terms of how they are seated in the airway. So the tip of the device really is lodged into the esophagus, and this bowl, this mask, forms a seal around the airway, hence the term laryngeal mask airway. And they kind of sit there, as you can see in this sagittal picture. The King is a little different. It has two cuffs, and it sits kind of behind the airway, whereas this small cuff is seated deeply into the esophagus, and the bigger cuff is seated at the base of the tongue, and air is delivered from this opening into the airway, as you can see on this sagittal picture. Now, some people actually call this type of airway an extraglottic airway because it's just outside of the airway. But just to be simple, we're going to call all these devices today supraglottic airways. That's what multiple organizations call them, and it's just going to be simpler to refer to them in that message. So when might you use a supraglottic airway in the emergency department? Well, in general, I think they're underutilized, and we really could find more opportunities to use them to help our patients. One of the most common reasons to use it would be if bag mask ventilation is tough. If there's like a beard or facial trauma or some other reason you're not going to get a good mask seal, or if there's something you need to bypass in the mouth. For example, if there's a tongue mask, the supraglottic airway might be able to get past it. If you have other resuscitation priorities, someone comes in, they're being bagged by EMS, and you need to put a chest tube in, you need to do a thoracotomy, you need to do some procedure where you need to take the focus away from intubation, put a supraglottic airway in, do those life-saving procedures, and come back and intubate later. Another great reason to use a supraglottic airway is right after you give RSI meds. This is termed a rapid sequence airway. So you give RSI meds as you normally would, and then to augment pre-oxygenation, or for someone who can't tolerate any apnea time, put a supraglottic airway in right after RSI meds, bag them up, improve their pre-oxygenation, and then proceed with intubation. In the operating room, there's actually some data that you can use these as a primary device for difficult airways. That's not really how we're going to use it in the ED, but that is an option. You can also use a supraglottic airway after failure of first intubation attempts or after failure of multiple intubation attempts. And this is perhaps their most valuable role in the emergency department compared to the pre-hospital space. And they show really good success at rescue oxygenation, really good success at rescue intubation in this setting when the first intubation attempts didn't fail. They will rescue you, and that's something to really keep in your back pocket and know exactly where your ILMA is, where your supraglottic is, and how to use it. There's not too many contraindications to the supraglottic airway. Certainly if you can't open the mouth, you're not going to be able to use this device. So someone's jaw is wired shut, there's some facial trauma that prevents mouth opening, you're not going to be able to use it. If there's a ton of fluids in the mouth, vomit, blood, just copious secretions of some sort, it's going to be really tough to use and probably going to be counterproductive. But there's not too many other true contraindications. Abnormal oral anatomy, tongue anatomy, laryngeal anatomy is not a contraindication to these devices, and they probably will work successfully in many of those types of patients. So in general, if you're using this to save someone's life, the contraindications are very rare.
I think you bring up a good point because if you can't open the mouth, you don't need to open the mouth very much to get really any of these devices in. You don't need to have a complete mouth opening. If you can get it open just a centimeter or two, you might be able to slip something like the King or an LMA through. So I've been in situations before where just getting the mouth open a little bit is all you need, and then you can put the supraglottic in and take a breath, take your time, and figure out your next plan. And I think too, with angioedema, as you mentioned, with airway swelling, just because the tongue looks really swollen doesn't necessarily mean I would still try a supraglottic, because generally once you round the corner, a lot of those structures might not be swollen, and the supraglottic will work really well.
Yeah, and there's no downside to trying. If it doesn't work, you're no worse off than you were before you started.
I do think too, when prepping, in our practice, we have 3 different supraglottics available. We've got the intubating LMA, the AirQ, and the King. I think having more than one is important. A lot of places only have one. I've had situations where all of these have failed in some way, shape, or form due to the underlying anatomy, or if there was an obstruction of some sort, but the other one has worked really well. So I think it is important to have at least 2 different types of supraglottic airways available.
Absolutely, I couldn't agree more. And one thing that we should emphasize, and when you're using these, this is obviously going to stimulate a deep gag reflex. You're only using this on someone who is flaccid or cardiac arrest or paralyzed, not using this on someone who is awake like you would for maybe some other airway devices.
Yeah, I think if you're going to put this into somebody with a pulse, they absolutely need to be paralyzed with a neuromuscular blocker.